Hello and happy Teach Me Tuesday. My name is Lisa. I'm an experienced NICU nurse and a NICU nurse educator here to break down another topic with you. Today is Tuesday the 18th. We just got done celebrating World Prematurity Day. Last week we talked all about World Prematurity Month and kind of what the state of prematurity is. And today we're going to dive more into the pathophysiology of a disease process that we see in the NICU that can affect premature babies as well as term babies, and that is Hydrops Fetalis. So Hydrops is rare, but one thing, first of all, I was asked to do this a few times. Number two, it scares me still. So anything that scares me, I'm like, we should really be diving into this. And number three, it is rare. So when we see it, I think sometimes we kind of forget what we had learned. So let's go back and think about it. It accounts for less than 1% of NICU admissions. So we are talking about a small little group here. I am going to talk a little bit about what you do, if you're a level 2 nurse and this is an unexpected delivery, or if you're a mom-baby nurse type of situation. But most often we know that a baby is going to come to us that's hydroptic. We know that prior to because of antenatal care. But this is about 1 in, 1,700 to 3,000 pregnancies. Used to be because of RH incompatibility, but we're better about that now. So the cases from that of immune causes from RH have come down, and now the primary reason is non-immune hydrops fetalis. These babies are going to show up very edematous, hypoxic, hypotensive, usually have a very hard time ventilating them, and they're going to need multi-system support. So let's kind of dive into what that means. Immune hydrops often does come from RH or ABO incompatibility, which causes severe anemia, which taxes the heart and causes fluid overload. That's kind of the most typical thing that we see. Probably saw that the most in my career at the beginning. Now we're kind of going into this idea of non-immune hydrops, right? Which is about 90% of cases of hydrops that you're going to see. It can come from cardiac malformations, chromosomal genetic orders, twin-to-twin transfusion, viruses, severe anemia, metabolic diseases. Sometimes it's unknown. One of the biggest ones I've seen in the last few years was unknown. We sent genetics. We sent a whole slew of different RH and ABO incompatibility. We sent like every virus you could think of, and nothing was really coming back. I don't know. Ultimately, that baby did not survive, and I don't know what the ultimate outcome was like from an autopsy or anything, but those are the kinds of ones that we see, and they are really hard. I got this, you see where I got this flow chart here, but really I wanted to point this out. I think we think that hydrops itself is a disease, and really hydrops is the symptom of what's going on with the baby, and I just want to kind of keep repeating that. And you have so many things going on, right? Liver failure, heart failure, volume overload, all of these things come together that your cells are depleted while the baby looks so edematous. So you have high interstitial fluid, nothing really going on in the cellular level, decreased lymph flow, and this is what's causing that hydroptic appearance. Again, most of the times we know antenatally. If there's good prenatal care, if there's any prenatal care, we know that this is going on. So it's diagnosed by ultrasound criteria where you have excess fluid in 2 compartments. So it can be ascites plus pleural effusion plus pericardial effusion plus skin edema. This is from the Cleveland Clinic. This picture is from there. You can see that they often have skin thickening. You might see polyhydramnios. This is very common in hydrops. They are often measuring the fluid levels. You're going to see an enlarged heart. You can have anemia or heart failure right away on that on the Dopplers. When this is seen, there are going to be so many maternal tests going on. So if you are a pregnant woman or someone that is going through this or supporting someone going through this, just know that that's going to be a lot. There's going to be a lot going on as they try to figure out kind of what's going on. So what are we seeing here? Again, this is another flow that I got from someone because it just looks so good. Why not use it and credit them here? We are seeing cardiac failure. We are seeing hypoproteinemia, lymphatic obstruction, capillary permeability. So all of those things are kind of coming together, especially in this setting of anemia, heart failure, and decreased lymphatic flow to cause this ascites, pleural and pericardial effusions, skin edema. The placentomegaly, I'm like That does not roll off my tongue. I'm going to be honest with you. But even the placenta is so stressed that it starts to get big. So just things to really think about of kind of the profound dynamic that's going on with this infant prior to them even coming out, and thinking of the stress they're already going to be under. So if you are the admit nurse or you're the delivery nurse, what is this baby going to look like when they come out with this cascade of events that's happening? So here we go. Ideally, we're going to deliver at a hospital with NICU, maternal fetal medicine, fetal therapy team, lots ready to go. Obviously, this could walk into anywhere. So if you, even in the moment or right before I find out, we got to think about immediate in difficult airway and immediate intubation. We got to think about getting emergency umbilical lines in. Where are chest or abdominal drains? So if you're in a high resource setting like a NICU with maternal fetal medicine, all of those things, you're going to have a team at this delivery, a big team ready with many hands to do many things. Same thing with your admission, and we're going to go into some things we would want there throughout this week, so stay tuned in my social media. We're going to see lots of fluid shifts. We're going to see really poor perfusion. These babies do not look good. And so we're going to really need to be coordinating these roles. What are we going to do? How are we going to communicate? What is our closed loop communication going to look like? How can we support each other and have the next thing ready to go, whether you're the admit nurse or you're at the delivery? So the baby's going to come. They are going to have generalized edema, respiratory distress, pallor, hypotension. I think the hypotension is really the hard one for people to understand. We're going to talk a little bit about that, but I really want you to remember the difference between this extracellular fluid and the intracellular fluid. That's going to really help you there. You would really think about difficult vascular access, like putting in a PIV, those kinds of things are going to be hard. We really are going to rely on that umbilical line. And then, of course, we have a risk of DIC. So what does our airway and ventilation support look like? Most likely these babies are going to be intubated. I have never seen like a severe, the hydrops you're thinking of, not be intubated. I also think I've always seen, I guess I shouldn't say always. We all know how I feel about always and never. Those are not Lisa's words. The majority of the time, they've had some amount of chest tube or a needling of their chest in some ways to get fluid off. I have seen a lot of pulling the ascites off, really helping try to get some of that fluid off with that paracentesis. So thinking about what that's going to look like during an admission and the care immediately after. Often these babies are 2 nurses to 1 baby because they are so sick and they require so much intervention. You got to have kind of all hands on deck. What is our ventilation strategy going to look like? I've often seen the oscillator for these babies. That's probably the most common mode of ventilation I've seen. Again, we're going to be balancing what we can do to support them and what they need. If you've heard me say it once, you've heard me say it a million times. There's no one mode of ventilation that's going to work in every situation. So watching what the baby needs and really responding to those cues. Lots of monitoring of your blood pressures, and then using my best friends, the RTs, to really work together to coordinate this. When you have a chest tube, you can have rapid shifts in your fluids. After someone has done a paracentesis and gotten fluid off of the abdomen, maybe your lungs have more room to expand, and all of a sudden the baby has a better ventilation strategy going on. So we have to think about those things and be prepared for those acute changes. Fluid and hemodynamic management is going to be huge. We are really thinking about what is going on with our intravascular versus extravascular. I don't like the word extracellular, in the intravascular space. We need to think about what our urine output is. I have talked extensively about how urine output is a huge marker of what's going on with the baby. We want to definitely be seeing more than 1 ml per kilo per hour. Make sure you know how to do that calculation. Make sure you're keeping track of that. These babies often end up on multiple pressors, dopamine, dobutamine, milrinone, epi, esmolol. There's a lot going on. One thing that you as the bedside NICU nurse are also going to need to be sure of is what's going on with your med compatibilities and incompatibilities, especially in the setting of getting blood products. So having a UA for blood pressure monitoring and maybe fluids, and then dual lumen or double lumen UVC is going to be clutch here. We're really going to need to have multiple points of access because getting IVs in and all that is going to be tricky. I am not going to sit here and be the expert and tell you what fluids should run and run not together. That is for you to work on with your pharmacist using up-to-date Micromedex, Neofax, whatever it might be, use your resources. Understand what you are doing and what needs to be widened and what cannot run together. Key part for NICU nurses. What's going on with our blood products? We might need to be giving RBCs. I have seen this for anemia or immune hydrops. Absolutely, I've seen that hydroptic baby when their RH was incompatible. We were giving lots of blood products. I've seen lots of albumin be given for these babies. So albumin, remember, is not considered exactly like a blood products like our RBCs or FFP and platelets type of thing, but it is often used in the setting to help with this oncotic pressure. So keep that in mind. Exchange transfusions happen once or twice a year if you're a big unit, less if you're a small unit. Look at those policies, know where your blood warmer is, know what your role is in it, who is keeping tracks of the ins and outs, how often are we doing our labs, etc. There's going to be so many labs. So again, this is why you need a UAC. You don't want to be drawing off that UVC that's got all those things going in it, and you're not going to be able to get capillary. We all know that everything's swollen. And then watching for bleeding and oozing of our lines. Additionally, things that you as a bedside NICU nurse need to know is continuous respiratory and hemodynamic monitoring your drains. We are going to talk about chest tubes this week and what their role is in this. I would say most of these babies end up with a chest tube, and this is one of those situations where you might actually have to exchange the chest tube drainage system, which with a pneumothorax, we are not usually doing that because there's not enough fluid coming out. But with the baby atriums, it can only hold so much fluid. For a hydroptic baby, you may have to replace that. So that's something to think about if you've never done that before. And what is the policy on your unit? What are you clamping off? Where are you clamping off? Making sure you're working with your experts on that. Stay tuned for more on chest tubes this week. Make sure you're collaborating with that multidisciplinary team. Again, RT is going to be your best friend. And how can we be helping our parents? So the initial look of these babies can be overwhelming, especially after we've put in some drains and we've intubated them and we've put lines in. Often these babies aren't held. I would say this is probably one of the biggest delays in holding I've seen in my career, especially in the last 5 years, as we are holding micropreemies earlier and earlier, as we should, and everybody should be being held. These babies are often very unstable, especially with their lines and their airway and how much fluid we are giving them, and the monitoring or the management of our different blood pressure medications. So I would say, how can we encourage them to be there, right? What can they be doing for touch? Are we changing diapers? Are we needing to change linens? Maybe we are changing linens more frequently. Maybe the baby's on a Chuck's pad or something because of the edematous situation going on. Can the parent be in charge of picking them up with help from your best friend, the RT, and other nurses around you while we do a linen change? How can we get them to the bedside and really understand how they can be a part of this care team? Can they be reading to the baby? Can they be singing? Can we be recording their voice? What do we need to do? If the baby is teetering towards a redirection of care, do we have palliative care involved? Have we called our chaplains to the bedside? Chaplains. I talked about this a few months ago. Chaplains are for everyone. Chaplains are not just for religious families. They are for everyone. Get your chaplain in there. They are great listeners and great support. So what is our prognosis? Mortality is high in this group, 20 to 50%, depending on the cause. Best outcomes are when you have a treatable etiology, right? So if we don't know what it's for, we often can't correct the actual problem, and so that's where it is. These babies have long NICU stays. They need lots of developmental outcome. Think about all of the fluids we're giving them, the different products we're giving them. So when you kind of put all that together, maybe they're on long-term ventilation, we can see what kind of our long-term morbidities are there. We need to have early identification and aggressive management. That's going to help with survival for these infants. So if I could give you 3 things that I wanted to make sure that you heard me say today. Number 1, hydrops isn't a disease. It's a symptom of severe fetal compromise. So it presents as the end result of an underlying disease. It can be cardiac failure, severe anemia, impaired lymphatic drainage. That is going to help you remember, you're not just treating this fluid, you're treating what's going on underneath so that we can help those organs not be in this severe fluid overload. Airway and perfusion are everything. That's number 2. So airway, getting that baby intubated, supporting the fluid on the lungs with chest tubes, etc., helping with ascites. Those fluid overload is going to change everything, and it can also, as we improve it, cause dramatic changes in respiratory and perfusion, fluid management quickly. So think about that. Remember, they're intravascularly depleted. So hypotension is very common. You're going to end up on many pressors. So number 3, and that comes back to kind of this idea of using your pharmacy and whatnot, organization and preparation are going to save lives. So if you know this is happening, gather your supplies. Where are your chest tubes? Have chest tubes, drainage systems in the room. Know where your blood products are. Be prepared for multiple IV lines, multiple kinds of fluids. Get your pharmacist involved early. What am I going to do if I have to add this in? What am I going to do if I'm giving albumin? What access do I have to give this? Make sure you're really thinking about those incompatibilities as you move through. That's going to help you be prepared and not feel caught off guard, because the sooner we can resolve some of these issues, then we can start resolving the underlying issue. So remember, we play a very pivotal role in this. We're going to guide the family as well. And so that's what another thing I just want you to think about is, how are we helping the family through this? In many ways, since this is often diagnosed prenatally, they're going to have some preparation of what's going to happen. But what can we do there with like being so focused on this technical preparation and precision and knowing which fluids are going where and what's compatible and is incompatible, while also having compassionate communication? Again, use your resources. Get the chaplain up there. Get another nurse. Have a nurse that can be the person talking to the family while you're doing a fluid change or adding a medication or changing your chest tube drainage system, so that we can really help them through this journey, especially if we're going to have any redirection of care. Thanks for joining me today. I will see you next week for another new topic, and it's going to kind of coincide with this one. So join me next week.